Hello, and welcome to today's webinar, Waste and Abuse in Behavioral Health, Trends to Watch in Medicaid and Other Lines of Business. I'm Erin Ressler, Senior Vice President of Payment Integrity Operations here at Cotiviti. Thanks so much for joining, and apologies, I am not on video. Of course, I had some technical difficulties leading up to the webinar today in true Murphy's Law fashion, and so apologies there, but the rest of the team on the panel, you'll get to see their smiling faces throughout the presentation as well. Before we get started, I wanted to quickly run through some housekeeping items for today's webinar. First, you can resize and move all the windows you currently see on your screen, including the slides and presenter video, to find the layout that works best for you. Next, we have multiple ways for you to reach out to us during the webinar. Along the top of the navigation, you'll see our Q&A button, which you can use to submit questions at any point during our time together. We'll do our best to answer these questions during the live webinar, and we encourage you to submit your questions throughout the presentation rather than waiting until the end to ensure that we get to your question today. You can also use the Contact Us button to send an email to us to request additional follow-up after today's webinar. At the bottom, you'll find additional resources, including links to useful assets related to today's webinar. Click the images on the right to view our FWA Insights blog series that we send out monthly, or you can read our ebook. And please use the Request a Demo button to get a more in-depth demo of any of our solutions. At this time, we don't provide copies of our slides, but a link to the on-demand recording will be sent to the registrants and attendees within a few days. For those of you attending today, the follow-up email will also contain your NHCAA attestation link to receive your AFI credit, and this credit is only available to the live attendees. And then finally, please take a moment at any point during today's webinar to answer our quick survey. Your feedback is extremely valuable to us and will help inform future webinars. So with that, let me introduce our speakers. I've already introduced myself, Erin Ressler, SVP of Payment Integrity Operations. I oversee our fraud, waste, and abuse solutions, as well as our coding validation and dental solutions here at Cotiviti. With me today is Nikki Brody. She is one of our SIU supervisors that leads a team of senior investigators who analyze complex claims data, identify emerging FWA schemes, and conduct prepayment investigations to protect our plan assets and support program integrity. Nikki also has over 20 years of experience in the insurance industry with 15 years in healthcare FWA. Kristen Hanna is our medical review supervisor that is one of our panelists today with 3 decades of experience in healthcare, including extensive experience in behavioral health coding, billing, medical reviews, and compliance auditing. At Cotiviti, she continually stays informed around Medicaid, Medicare, and commercial payer policies and guidelines to help develop behavioral health policies and guidelines for content libraries. She also oversees our FWA post-payment medical review team and documentation audits. And then finally, Andrew Weinbrenner, our senior investigator with us today, is responsible for analyzing claims data to identify potential instances of FWA among medical providers as he conducts post-pay FWA investigations on behalf of health plans. Before joining Cotiviti, Andrew was an investigator for a national health insurance plan where he specialized in Medicare FWA investigations. Finally, before we get started into the great content we have for you today, just a quick disclaimer. The contents of this presentation, both written and oral, are not to be construed in any way as legal or medical advice. This presentation is for informational purposes only. The views and opinions expressed in this presentation are those of the presenters and do not necessarily reflect the official position of Cotiviti. All righty, so let's jump in. First, I'd like to just set the stage of what we're going to talk about today. First, we're just going to talk about just generally what the pulse is in the market around behavioral health and what's new in FWA. We'll also look at some key risk areas within the behavioral health space, as well as generally across what we find for our clients in both post and prepayment review for FWA. We'll also dive into what reviewers and our SIUs should look for. And then finally, we'll wrap up with a case study. So before we do all of that, what I'd like to do is set the stage for the conversation. All of us working within fraud, waste, and abuse investigations understand the magnitude of the problem we're trying to solve. I thought that this graphic would be a great depiction of how we can just kind of carve out and take a look at the areas where we're seeing pockets of fraud, waste, and abuse. And how we're seeing shifts in that landscape just based on advanced technology, heightened regulatory scrutiny, evolving behaviors both because of AI and in response of AI, and then expansion of digital models that we've seen year over year for the past 5 years. So Nikki, I thought this would be a good time for you to give us your perspective on what you're seeing shifting in these areas as we move through the presentation.
Yeah, absolutely. Thank you, Erin. So some of the things mentioned here are evolving in billing behaviors. So we're looking for things like claim resubmissions, specifically with changes in like modifiers, units, or codes billed, some improper payments. So even some of those really small inconsistencies can eventually add up to high dollars if they're not caught early. And then we're looking at the complexity and scale, right? The variability that makes it more difficult to identify those early on. So ensuring that you're just doing a full deep dive into that stuff. And then of course, early identification. So early detection's key. It's really, really important to make sure you're looking at things like frequency of visits, repetitive billing, mismatched diagnosis and treatment is a really big one. And then just not looking just for the outliers, but also looking at the provider's overall billing trends and how it's changed over time. And then, of course, we're looking at targeted prevention strategies. So things like sudden changes in billing, increases in dollars, and then improper specialties, billing for services that they shouldn't be billing for. And then a clear difference between unintentional errors and potential abuse. So one-offs are one thing. Those are usually explainable. But the repetition is what really stands out. So repetition leads to intent. So that's something that's really important to make sure that you are looking for.
Awesome. Thanks, Nikki. So kind of leading into the depth of our conversation today, what we'll be talking about is not just behavioral health, but changes we've seen, again, in the fraud, waste, and abuse landscape, and just generally in the service models that are being used more regularly. So since the pandemic, we've been tracking kind of percentages of where claims are being billed and how patients are receiving care. Obviously, telehealth has had a number of changes over the last 2 years, some of which have just been made permanent, which Kristen will give us an overview in a little bit of. But again, this is just one of those nice graphics for you to see where we've seen the distribution in terms of place of service and how patients are receiving care over time. Obviously, we would anticipate to see telehealth on the rise because it is more broadly used across various specialties. But it is interesting to sort of track where we're seeing those pockets and how they impact what we review for fraud, waste, and abuse. Another area that we're going to touch on really quickly here too as well, and I believe Kristen's got some insight on this from a review perspective, is again, just tracking the behaviors over time that we've seen rise in certain areas. And obviously, in many cases, very legitimate claims. We're seeing legitimate therapies for 60 minutes at a time. But what we're starting to see is the utilization and the shift from the shorter services to the higher level services. And across the board. So seeing those patterns that Nikki mentioned, looking at the repetition, where do we see potential inappropriate behavior? And so again, this is one of those really interesting graphics that we use to sort of gauge where we are in certain areas. And certainly this is a hot button issue that we've been tracking for some time. Kristen, did you want to give, some thoughts around what you're seeing from a reviewer perspective for the 60-minute therapy sessions?
Yeah, basically all we ever see really is the 60-minute codes. I can think back on many reviews that we've done for psychotherapy, and I can hardly think of any that had a 30 or 45-minute code. It tends to be that 60-minute code they always go for.
And is that, so I don't want to put you on the spot, is that because we're targeting the right providers, or is it just maybe a broader use of the 60-minute?
Well, I think it's probably a little bit of both, but I think it's that we're targeting the right providers for sure, definitely, yes.
Okay, great, thank you. All righty. So really quickly on some of the areas where we've had some vast experience and some really good findings. We've talked about high ratio of psychotherapy services specifically for the high level. These are just some other key areas that we've been tracking, some of which we're going to touch on today. I want to hone in here on ABA because I know we're going to talk a good bit about that later. But just, some perspective there, we look at ABA therapy both in post and prepayment, knowing that it's a sensitive topic and also can be a bit sensitive with the provider population we're working with. They're very vocal, really thinking about targeting the right providers at the right time, which is Kristen, I asked you that question before. But many of our clients tend to exclude certain ABA providers, again, just to take a very strategic approach to this area, given the sensitivity of the topic and also just the vocalness of this provider community. But in many cases where we do conduct a clinical review, what we're finding is that we're missing key pieces of information, again, sometimes in a pattern of potential waste and abuse. Other times may just be billing or documentation errors, but many amendments that are outside of the CMS protocols, missing clinical information, resulting in about 80% of those records that we receive in a denial. Other areas where we see some problematic billing and documentation is telehealth services not being properly documented, suggesting that potentially the service was not performed, face-to-face time not being documented, et cetera. So I don't want to get into too much of the detail here, but this is just to give you a little taste of what Kristen's going to talk about here in a few minutes. All right. So with that, Kristen, I'm going to hand it over to you for some of your insights on from a medical review perspective.
Yeah. Hi, I'm Kristen Hanna, and it's my pleasure to be here with you today. I'm Supervisor of Medical Review for Cotiviti. And it's interesting that 2026 has turned out to be a big year for behavioral health regulations and policies. We're seeing some substantial changes with higher documentation expectations, along with pushes towards telehealth. And for telehealth, a major change is CMS has converted back to pre-pandemic guidelines for telehealth services regarding geographic restrictions. So those geographic restrictions have been permanently removed for the diagnosis and treatment of behavioral health services, including substance use disorder and treatment. Another change comes along with Section 1834 M of the Social Security Act, requiring an in-person non-telehealth visit within 6 months prior to the initial behavioral health telehealth service for patients beginning January 1st, 2028. For anyone receiving behavioral health services on or prior to December 31st, 2027, they will be considered already established, and they'll only require at least one in-person visit every 12 months after December 31st, 2027. And regarding the use of the audio-video platform, behavioral telehealth services provided in the patient's home can still be provided by audio-only platforms if the provider is not technically capable of using that audio-video technology, or if the patient is not capable of or does not consent to use of audio-video technology. And the provisional telehealth services for behavioral health have actually been moved to permanent telehealth services list. So all of those provisional services that we didn't know if they were going to stay on the list or not, they have all been made permanent. So some interesting changes with telehealth this year for behavioral health.
Mm-hmm. So more changes to come and more to look out for, right, Kristen?
Yes, definitely, definitely. It seems to be ever evolving. Another topic that we're seeing changes for in 2026 are for value-based payment models. And they're becoming a lot more prevalent. CMS has introduced Behavioral Health Integration Services, or BHI, as I'm going to refer to, which allows primary care providers to be reimbursed for coordinating behavioral health care. So this includes collaborative care models where medical and behavioral health providers work together. BHI is a monthly time-based care management service that involves an initiating visit to establish that relationship with a billing provider. And this can include direct patient contact, face-to-face services, or even services without direct patient contact are included, and may be provided by members of the care team as incident to under the direction of the billing provider. And there are actually two types of BHI services. The first is Psychiatric Collaborative Care Model, or COCM, as I'm going to refer to. And the second is the general BHI services using care models other than COCM. So with psychiatric COCM, this includes a team of 3 with a behavioral health care manager, a psychiatric consultant, and a treating practitioner. And that treating practitioner and care manager are going to work in collaboration with that psychiatric consultant, and they're going to add 2 key services to primary care. Those 2 key services are management support for a patient receiving behavioral health treatment and a regular psychiatric interspecialty consultation. With the general BHI services, this consists of other BHI care models in order to thoroughly assess and monitor patients, adjust those care plans when they're needed, and to provide that continuous relationship between the patient and the appointed care team member. General BHI includes care management services for behavioral health conditions, so you can't report general BHI codes in the same month as psychiatric COCM for the same patient. There are other BHI-related services introduced in 2026 that also include add-on codes for advanced primary care management, or APCM, which will allow psychiatric COCM or general BHI services to be billed as add-on codes with primary care, as well as expanded interprofessional consultations, safety planning and crisis care, and digital mental health treatment codes. And actually, the digital mental health treatment codes will pay for a digital treatment device with the software that's actually been approved by the FDA to help those with ADHD. So see, these are some of the many changes related to the 2026 changes in behavioral health care. And next you will see on the next slide the relevant CPT and HCPCS codes. And we're going to share these along with the slides after the presentation. And you can see there that we have the initial and subsequent psychiatric COCM codes. We have the general BHI care management service. Then we have the add-on codes that are to be billed with the APCM base codes. We have the interprofessional consultation codes, safety planning and crisis care, and the digital mental health treatment codes. And just for your information today, the case studies that we're going to talk about are going to be related to ABA services, applied behavioral analysis, and these are the CPT codes and HCPCS codes that we will see that will be included with that.
Kristen, a question for you. How do you see this as a challenge from an auditing perspective?
I can actually see a couple of things. I see the add-on codes being a challenge as far as possibly being billed without the base codes, or you could see billing both the psychiatric COCM and general BHI in the same month, which we know can't be done. Also with documentation, we could possibly see missing documents from all the members of the care team to show that that collaboration and coordination is occurring. So I could see those things happening.
Yeah, for sure. I think too, beyond fraud, waste, and abuse, I think just generally speaking, every year we're staying ahead of coding updates and applying that to our editing solutions, et cetera. But I think these types of changes, you certainly have to think ahead and be, ready for them and not in a reactionary mode, so you can kind of stay ahead of some of these big changes, because otherwise you're sort of just continually trying to keep up and tread water. But I think it'll be good for folks to keep a lookout for these things, as well as, some of the changes you highlighted previously around the changing landscape around telehealth as well. So, so thank you for your insight there.
Sure.
All right. So I think it's time for our brain break, which is always fun. So if you've attended any of our webinars before, we try to keep it light and give you a break from all of the deep thinking around fraud, waste, and abuse. If you know anything about me, I am a very big Harry Potter fan, and so I like to insert that in any place I can. So thank you, Beth, and our marketing team for making that happen today. But just opinion, no right answer here. Which of these con men film characters do you love or love to hate the most? I'm torn between A and B here. Certainly, Gilderoy Lockhart is one of my favorite fraudsters, obviously because I'm partial to Harry Potter, but I did love Better Call Saul and also Breaking Bad. So he's one of those you love to hate. So anybody else in our group have an opinion while folks are weighing in?
I'm a little bit partial to all of the Ocean's movies, so that would be my vote.
All right. I like it.
I'm partial to Eddie Murphy, so I have to go with Billy Ray Valentine.
I'm a big fan of Better Call Saul. I actually used to live in Albuquerque, New Mexico, so there was a lot of Breaking Bad fans out there, obviously.
Oh, awesome. Yeah, for sure. All right. Let's see what we've got here for our results. Oh man, we have a pretty even split here, with Harry Potter not coming in last. So I feel really good about that. So thank you, everybody. All great movies and TV shows, but if you haven't seen them, go watch them. All right, let's get back to the serious stuff for a little bit. So I think, Nikki, you're going to take over here and talk a little bit about an ABA therapy case study. And I realized we have not also shown what ABA stands for in the slides here too. So maybe you can talk just briefly and give people a little notation on what that is exactly.
Absolutely. Thanks, Erin. So I am going to go over an ABA case study. And that is going to be a prepay case specifically. But to get back to your ask, Erin, so ABA stands for Applied Behavioral Analysis. This is a behavioral health therapy, typically related to autism specifically. So for this particular case study, this was a prepayment case that involved an ABA provider who high level had a combination of high utilization and concerning billing patterns surrounding ABA therapy and those procedure codes that Kristen had previously mentioned. We saw for this particular provider excessive daily hours that just didn't quite align with clinical feasibility. So especially if we're taking into consideration drive time, documentation requirements, all of that sort of thing. So she was billing a lot of hours. We'll just put it that way. A lot more hours than what would be typical or what would even be feasible. On top of that, she was a clear outlier compared to her peers. So she definitely stood out. It wasn't just a little bit. She was far above the rest. And then some additional things that we saw were time-related concerns, and not just the excessive hours, but also billing on weekends and patterns that just didn't really match up with our typical ABA models. So from there, we also looked at it from a coding perspective. So she was billing way over the CMS medically unlikely edits or MUEs, which is certainly something we don't want to take lightly. I mean, those thresholds are in place for a reason. So we did notice that she was completing that or billing those as well, and it just was outside the norm. So before placing her on prepayment, this is where it gets a little bit interesting, we did a license verification. And upon reviewing her license, we found that she actually hadn't been appropriately licensed during the entire duration of her billing the client. So her license wasn't actually active for about a year after she already started billing. So that immediately prompted us to recommend that she be placed on review. From there, we began requesting medical records. And we noticed that the documentation was a big concern. So when we started receiving those in, we weren't just seeing like minor errors. These were consistent problems throughout multiple areas. So essentially the things that we noticed in her behavior based on her, the analytics were proven in the documentation itself. So some of the things that we saw were missing components or lack of detail in the documentation. Consent, she had a lot of consent issues. So either the consent was missing entirely or it was inconsistent. We had missing signatures, or sometimes there were people who signed the consent forms that were not the parent or legal guardian of the minor that she was performing services on. In addition to that, we saw contradicting diagnoses between one set of records and another set for the same patient. So she was kind of bouncing between multiple diagnoses without any rhyme or reason. So once one more thing that we noticed that was very concerning, and I think anybody who's been in the FWA world for a while will agree, she was frequently cloning or templating notes. So we were seeing consistent notes from one patient to the next, which is a huge red flag on its own. And then once she noticed that we were denying a lot of her records, or the majority of her records, she started to shift her billing. And this is where I think prepayment comes in and kind of has a leg up on some of the other things that we see, so we can stop this at the forefront. So she started billing codes that we didn't previously have flagged, which led us to then expand the review to include those additional codes. We did have multiple conversations with this provider. She had hired a new coder and an attorney to have those conversations with us. And during those discussions, one interesting thing that came from that is that the provider indicated that she would adjust her documentation however she needed to get the claims paid, which is obviously a huge flag, raised some concerns about potential falsification of records. So based on everything we identified, and the provider herself was ultimately removed from the client's network, stopped billing altogether, thankfully. And for the very short time that they were on review, we had a savings of over $100,000 for that one provider.
It's a great success story. And I think as many payers are moving more to prepay, this is a great example of taking a really thoughtful and strategic approach to what we place in prepay versus postpay, understanding that, an ideal state we could shift left as much as possible, but obviously postpay is ultimately part of the picture, and I think will serve a purpose for making sure that we can identify all inappropriate behaviors across the continuum and make sure we get the full picture for the provider. So it's great that we'll hear from both perspectives today. All right, so Andrew, I think you're up next to talk just that, post-pay.
Hi everyone, I'm Andrew Weinbrenner, a senior investigator here at Cotiviti. I primarily work on post-pay cases and bring 8 years of SIU experience, including my time here at Cotiviti and previous with a national insurance plan. I wanted to build on the prepaid discussion that we just had and highlight some significant changes we've seen since Medi-Cal launched its behavioral health transformation as part of CalAIM in 2022. This initiative expanded behavioral health services and made them easier to access. In July of 2023, as part of that initiative, the county behavioral health plans moved from a cost-based reimbursement model to a fee-for-service model. And as many of us know, expanding these benefits and introducing new incentives can at times attract bad actors. For example, one of our county health plan clients in California, serving mostly Medicaid members, saw a substantial jump in paid claims with autism diagnosis and high utilization of HCPCS code H2019, starting in 2023, with increases continuing year over year. This graph here is going to give you a great visualization of these types of jumps we're seeing. As you can see, it's pretty flat line from 2020 to 2022, and then once these initiatives were introduced, we saw a rapid increase in these billings. HCPCS code H2019 became the plan's top billed code, with over a 300% increase from 2022 to 2025. Over that same time period, diagnosis code F84, representing an autism diagnosis, is now the top paid code for that plan by increasing 250%. These large jumps year over year led us to start looking for outliers within those time periods and within these codes. What we found were several providers presenting as extreme outliers, with many of these providers first billing the plan in 2023 when these initiatives were introduced. Additionally, we saw a pretty big overlap between the HCPCS code H2019 and autism diagnosis code, with a large majority of the outlier providers within the H2019 data using that autism diagnosis code for 100% of their claims. As an example, one of these outlier providers, when we benchmarked them against their peers, we saw that the provider was paid more than 3 times their peers on a paid per patient basis. Additionally, the provider utilized diagnosis code F84 for all the claims billed to the plan. A medical record review audit was then completed, and it identified several issues. Kristen, do you mind detailing those issues for us? Because I know that there were some very interesting findings for this case.
Yes, there were. Thanks, Andrew. Yeah, lots of issues noted in this one. One major issue identified was related to the supervision of the ABA services. 21 different providers were identified in this review as either rendering or supervising. And after searching the Behavioral Analyst Certification Board registry, only 8 of those 21 providers were found to be certified. So what we determined was there were a variety of providers, including board certified behavioral analysts or BCBAs, qualified autism service or QAS professionals who are supervised by a BCBA, and QAS paraprofessionals who are typically your registered behavioral technicians, and they are supervised by BCBAs or QAS professionals. So the documentation reflected that QAS paraprofessionals were supervising other paraprofessionals, which is obviously not allowed. The documentation also referred to those paraprofessionals as behavioral analysts. In addition to the supervision findings, the medical records were deficient in several ways. There was no referral from a physician or a psychologist, which is required for ABA services by this plan, and there was no initial assessment or treatment plan submitted. The daily treatment notes didn't contain the rendering provider's credentials, and actually the supervising provider's signature was only the first name. So some providers couldn't be validated as licensed or certified. The narratives in the daily treatment notes were not sufficient to support the total time documented and the number of units billed. For instance, the narratives indicated recreational or non-therapeutic activities were performed, such as things like snack time and playing outside and watching TV, which obviously can't be included in the time spent. We also saw improper use of modifier 95 indicating telehealth, where it was applied when the daily treatment note did not indicate telehealth services occurred or wasn't applied when telehealth was indicated in the note. Also, the wrong place of service was billed, where services treatments were performed in the home, but the place of service on the claim was 11 for office. The medical record for one patient reflected overlapping times, as we actually saw 3 different notes for the same time on the same date of service by the same rendering provider. So obviously some overlap there. The HCPCS code S511 for home care training for the family is a per session code, yet it was billed as 15-minute increment code with anywhere between 4 and 8 units on a single data service. So there were many issues noted within this documentation for this review. Andrew, what were the final results of that case?
The case actually ended up with a 100% denial rate and an identified overpayment of just over $100,000. Based on those findings, the plan did elect to expand the scope of the audit, and that expanded review is still ongoing. Kristen, have you seen this type of behavior in other providers?
Yeah, actually we have. I was thinking about a couple of more case studies for another client where we identified some of the same documentation issues. We saw again that the medical records did not contain a referral. Behavioral identification assessments and treatment plans were either not submitted at all, or when they were submitted, there was missing documentation, missing elements such as discussion of the findings and recommendations, and scoring and interpretation of the assessment. The adaptive behavior treatment notes were missing start and stop times and or total time spent. Or if the times were documented, the narrative about the service provided only contained a brief description with just a few short sentences that weren't sufficient to support the time. One note that stands out to me seems like the narrative was something like, we played with Legos and put 2 puzzles together and the sitter was present during the session, and that's all it said. Many of the notes were missing progress toward patient-specific goals noted in the daily treatment plan. daily treatment notes were not signed by the rendering or supervising providers, or the signatures that were in the notes indicated someone other than the billing provider had performed or supervised the service. So in that instance, we had identified potential pass-through billing. Also, some signatures didn't contain credentials to determine if the provider was licensed or certified to perform the service. So again, many documentation discrepancies noted within these reviews.
Kristen, what kinds of things would you look for within the medical records? And just kind of, referring back to our overarching theme for this conversation, there must be some areas that we could give as takeaways to our audience today.
Definitely. When it comes to documentation for behavioral health claims, we have several things that we're looking for to begin with. We're looking for that written referral from the referring provider when the plan requires it. We look to see who provided the service and are they licensed or certified. We're looking to see if the billing provider was the person who performed or supervised the service and if they signed the documentation with their full name and credentials. For the initial assessments and treatment plans, we're checking to see if all the required elements of the CPT code are present for the assessments, and also if those treatment plans have targeted measurable goals. For time-based codes, we expect to see either the total time or the start and stop time, or both, based on whatever the payer requires. And for those times, we're verifying for overlapping services and overlapping times between providers and patients on the same date of service. Within that narrative of the daily treatment note, we're checking for sufficient documentation to support the time noted and if therapeutic activities are documented. And we're looking at the interventions performed so that we can see if they tie back to the treatment plan and if there's documented progress toward goals listed in that treatment plan. Obviously, this is not an exhaustive list as there are nuances to each review, but this is what we start with. So with all that said, there is the potential for FWA exposure within these issues. You could have providers performing or supervising services that are not licensed or certified, which obviously we have seen in prepay and postpay today. You may see coding issues with incorrect CPT or HCPCS codes based on the service documented. There could be possible concurrent or duplicate billing, where you may see notes reflecting the same patient is in two different locations at the same time. There is the potential of non-covered services, as the documentation may indicate recreational or non-therapeutic services occurred. And also where the data may show a high amount of units billed, the amount of units billed simply are not supported by the documentation. So when we talk about good versus problematic documentation, I think we can sum it up in that good documentation is going to be objective and measurable with individualized and detailed information to clearly explain the therapy service that occurred. This should include well-explained interventions, obviously, that need to tie back to the treatment plan, the goals in the treatment plan, along with the behaviors observed, and includes progress toward goals. All documentation should contain appropriate provider signatures to include credentials in order to reflect the provider possesses the appropriate licensing and certification to even perform the services being billed. Bad documentation is subjective and vague. The daily treatment notes may have incomplete intervention details along with missing information, such as no time spent, no documented progress toward goals, and not appropriately signed by the provider with credentials. So that pretty much wraps up the medical review perspective and what we look for within medical record documentation. So now we'll go back to Erin for one more fun brain break.
That's good. Thanks, Kristen. All righty. So another good one, more about our famous fraudsters. Which of these didn't really happen? So we've got a good mix here. Again, thanks to our team for putting these together. Take a read. I'm not going to read them out loud because I don't want to give it away. But we've got some great celebrities in here, Shirley Temple, as well as Milli Vanilli. And for those of you that are a younger group and may not be familiar, maybe like one of our panelists here, Milli Vanilli was a 90s pop duo that lip-synced a song recorded by studio singers. And fun fact, Weird Al also did a cover of their song, changed the words like usual, so maybe give that a listen. Being from New Jersey, I'm very familiar with our Real Housewives of New Jersey. So Well, again, I don't want to say too much more because I feel like I'm going to give it all away. But any other fun tidbits from the group? I've got some other fun facts about our famous fraudsters as well. In the early 60s, Shirley Temple served a short jail sentence for running an illegal gambling operation in Florida. I'm pretty sure we all knew that was the one that wasn't true, right? In fact, she was an upstanding citizen, and she was the first female U.S. chief of protocol. So if that one wasn't obvious, that's your answer. The rest of these did happen. So hope you enjoyed the second fun break here. And with that, I'm going to hand it back to Nikki. No good presentation ends without some takeaways and some homework. So Nikki, if you want to take it away and kind of give our folks the recommended action plan that we've provided for them.
Absolutely. Okay, bringing it back, and let's walk through quickly what a action plan might look like for you. So thinking Monday morning, we would want you to focus on high risk behavioral health services and providers to look for outlier billing patterns, things like excessive daily units, overlapping services, high frequency visits per member, that type of thing. And you're going to take a look for both current prepayment and post-payment coverage to spot any gaps where high risk services might be slipping through. Over the next 90 days, you're going to dig into the provider's billing patterns across NPIs, affiliated groups, tax IDs. Look for differences in utilization, documentation trends, and potential risk indicators. And then you're going to bring together anyone who might be impacted by any of those changes. That might include clinical, coding, SIU, maybe networks, that type of thing, to make sure everybody is aligned on what the documentation should be, what the billing expectations are, and that will in turn help you reduce any provider abrasion. And then for the next 90 days to roughly a year, you would want to work on improving data integration across services so it's easier to identify patterns at an organizational level. Even with any current system limitations that you might have, it's still going to be just as important. You're going to want to standardize review pathways based on the service type and complexity to drive more consistency and efficiency. And then make sure you continue to refine clinical and coding review logic. Kristen had mentioned before about all these changes that are coming into play, making sure you're staying on top of those trends and the changes that come down from CMS and whatnot, and focus on emerging trends. Some of those things might include telehealth, documentation changes, new billing outliers. Be on the look for those as well. And then long-term, support long-term compliance and provider engagement by focusing on education, transparency, which is going to be huge with that provider abrasion, and then targeted interventions to improve overall documentation and billing accuracy. Now I'm going to pass it back to Erin so we can go over some Q&A.
Thanks, Nikki. And again, if you haven't done so, quick reminder, you can still submit questions through the QA button. So let me just take a read of some of these questions. I think this first one, Nikki, I think you can address. What are the earliest signals teams can act on from cases like this, and how should that translate into Monday morning actions versus a 90-day plan?
Yeah, great question. So for us, the earliest signals are going to be usually pretty consistent. So things like providers who are clear outliers compared to their peers, excessive daily units, billing patterns that just don't make sense, clinical-wise, like overlapping services, unusual weekend activity like we discussed in that previous case study. And then from a Monday morning standpoint, you're really look for identifying those outliers quickly and make sure that you've got the right prepayment edits or reviews or people in place to make sure you can identify those high-risk services. And then over the next 90 days, take a deeper dive, look across affiliated providers, really make sure everybody who's involved is aligned and everybody's got the same focus. That's where you're going to start to see more of the meaningful and impactful consistency.
All right, great. Thanks, Nikki. Kristen, I think next one's for you. What would you expect to see in the behavioral health daily treatment notes as far as progress towards goals listed in the treatment plan?
Yeah, great question. There should be documentation that indicates the specific goals to be achieved, as well as the interventions performed during the therapy session. And the treatment record should also contain documentation if the patient is meeting goals that were established during their initial evaluation or reevaluation.
Great. Let's see what else. We've got some great questions in here. All right, so Andrew, I think I have one for you. How does the shift from cost-based reimbursement to a fee-for-service model create greater opportunities for provider FWA?
Yeah, sure. That's a good question. Moving from a cost-based model to a fee-for-service shifts payment from covering overall care costs to paying for each individual service, which this will lead to a change in provider behavior and billing. This model can incentivize higher service volume, sometimes leading to overutilization or inappropriate billing because the providers are paid more as they deliver more services.
Thanks, Andrew. All right, so this one I can probably take. There's a question around medical records and asking, do we always request medical records, or is that at the client's discretion? Obviously, the answer is yes. There is obviously the client's decision-making plays a part in how we provide the service to our clients. In our case, we are typically at the end of the cycle in terms of what we offer a client for payment integrity, program integrity efforts, meaning that we have other solutions upstream that work in a more automated fashion where you can address the billing in an automated way. Then there's more of like a human in the loop type review where you've got a pause and pay solution where we look at coding insights and clinical review to determine if a claim should be paid. Then when it gets to us, we're really addressing a pattern of behavior that we have identified through various means, including analytics or insights from other client data. And so many times we are requesting the records to then corroborate what we're finding in the data, because it does really give our clients that sort of handoff and that fully vetted case that they could take and take investigative action or, action through their network to address the behaviors. It also serves as an educational document, right? So if we've backed up the data with the documentation and we can address maybe an educational concern or just an error, we'd love to be able to do that. And without a record, that can be difficult, not to say impossible, right? Because there are situations where we've identified a pattern over time cross-payer where we can confidently say that we know what the issue is. We can take those measures as well. So it is certainly a combination, but ultimately most of what we do includes a record for that fact. All right, so let's take a look at some of these others. Give me a second. All right, there's a lot coming in here. This is probably for the whole group. So whoever who has good insight here, just chime in. Has anyone encountered excessive use of 80023, 25, and 38 ABA codes for substance abuse outreach? No base codes used. So, team, any insight there?
I can't recall doing a review with any of those codes, but that is a good question.
Okay. Yeah, might be something we could take back and kind of provide some insight from our team. Yeah. That sounds good. Okay. There was a sampling one in here. Maybe Andrew, you could take this one and I can chime in for you as well. How do we determine our samples?
Sure, yeah, I can help with that. Answer the question. It honestly depends on whatever state regulations or federal regulations your plan might fall under. But typically we want to do a targeted sample where once we've done our analysis of the data, And we've targeted a few different scenarios, whether it be multiple codes built together, certain place of service being built with it, or a diagnosis code. Once we figured out our target suspect behavior, that's when we will either do a probe sample where we're picking and choosing, or we might do a statistically valid random sample where it is a tool used by OIG and HHS where it will randomize that sample for us.
Great, thank you. And that also, to some degree, right, has some client approval and decision making there as well as we formulate those on their behalf, based on varying regulations for sure. All right, let's see. Okay, so maybe Kristen, this might be a good one for you. Have we seen an influx of E&M codes built with unsupported psychotherapy? I think the answer is probably yes, but I don't want to speak for you.
Yes, we have. We have seen that. And oftentimes what we come to find out after we look at the documentation is there is no E&M. It was simply just a psychotherapy service, and they probably had medication involved. So that's where they think that they can charge for that E&M service also, but it ended up being just a psychotherapy service and medication. So the E&M was not supported. And many times that's what we see.
Yep. Okay. This is another one for you, Kristen. Sorry, I'm keeping you busy here. How often do you look to see the treatment plan updated?
Well, really, that depends on the patient. What we see in the medical records, we want to see, there's not a certain time, like it doesn't need to be every 90 days or anything like that. But what you're looking for is if you see a change in the patient, like in the therapy that's occurring, or something that's changed in the services that the patient is receiving, then you would want to see that treatment plan that ties back to the changes for that. So like, for instance, you may have a record where you have the initial evaluation and treatment plan. That treatment plan shows one thing. Then as you get into the daily notes that have been submitted, and I see a change in interventions performed and things like that, something that looks different, then I want to see that treatment plan that also shows that that's the change that should be made in the services they're receiving.
Mm-hmm. Okay, great. So I'll take one to give you guys a break here. We have a question around cloning and templating. So when we come across templating, copying, and pasting, providers seem to be blind to this. What is the best way to address this? So this one's a really interesting topic given the AI world we live in. And so there's many ways that we look at clones, documentation, templating, et cetera. And so some templating you would expect to see across records, but others you should not, and whether or not it's intentional or is a mistake. And so it really depends on the provider you're working with. So if you have seen very glaring issues in the documentation, and Kristen, you can chime in here too in a second if you'd like, but you see really glaring issues here that would suggest potential intent to bill and document inappropriately, then that's one thing. But if it's educational in nature, that can be addressed through a simple educational call with a provider, an audit findings that outlines the deficiencies and how they can improve, and then pairing that up with a corrective action plan that requires the provider to make meaningful improvements in their billing and their documentation. Sometimes this also could be an unknown to the provider, right? And so if they've got an office staff that's maintaining their records and maybe making some mistakes on their behalf, either intentionally or unintentionally, again, that's where education comes in to provide the provider that insight. But Kristen, anything big I missed there, and from your perspective?
No, I think you pretty much got it. We can typically tell in the notes when we see that cloning if it seems to be intentional or not, and a lot of times it is educational.
Yeah, maybe just think about the tools in your toolbox. The human review coupled with the technology you have at your disposal. If we've seen an uptick in AI generated records. If you have an AI capability that can pick up on these things, great. But also make sure that you rely on your subject matter experts that you have on your team as well. All right, so we are going to wrap things up here. So just Again, quick housekeeping before we wrap up. Thank you to our speakers, Nikki, Kristen, and Andrew, for your insights today. We'll be reaching out to you via email shortly with a link to the on-demand webinar recording. And don't forget to take a moment to answer our survey. We really look through all of those comments, and we take the feedback seriously, and we bring it into our future webinars. So please fill that out. And with that, thank you for joining us, and we look forward to seeing you again soon.